A history and overview of the 10 building blocks of high-performing primary care. To achieve the quadruple aim of health reform, better health, improved patient experience, more affordable costs, and the work-life improvement of those who deliver care, we need a foundation of high-performing primary care. Many exciting efforts are underway to re-engineer primary care practices. To help facilitate these efforts, practices can benefit from a roadmap to help navigate the journey from old to new. In this presentation, we'll describe a conceptual model that guides our work as practice improvement facilitators, the 10 building blocks of high-performing primary care. This model represents the synthesis of our thinking from over a decade of observing and experiencing improvement work in primary care. The development of the building blocks framework was based on case study methods using information from several sources, site visits to 23 highly regarded practices, the team's experience as practice facilitators in more than 25 practices, and a review of existing models and research on primary care improvement. Practices were selected for site visits on the basis of being identified by their peers as innovators and high performers in one or more of the triple aims. The 23 practices included 8 hospital-based clinics, 7 integrated delivery system sites, 6 federally qualified health centers, and 2 independent private practices. 7 of the 23 practices had 5 or fewer physicians. These case studies and coaching experiences yielded insight into some common attributes of high-performing primary care. By comparing and discussing field notes, we identified a set of elements, building blocks, that occurred with regularity among well-functioning practices. We cross-referenced emerging building block concepts with themes articulated in other published frameworks to look for shared elements. These frameworks included the Joint Principles of the Patient-Centered Medical Home, PCMH, various medical home recognition standards, the change concepts for practice transformation, University of Utah's Care by Design, and published research on practice transformation. We also vetted the model with practices during our work in the field and refined the model in response to their feedback. So what were the common attributes of high-performing primary care that we identified? At the foundational level, we have the attributes of engaged leadership, data-driven improvement, empanelment, and team-based care. Although the practices we have studied and coached vary the order of how they implement the building blocks, many have first established these 4 foundational blocks before achieving success in the higher order blocks. Let's take a look at each of the building blocks, starting with the foundational ones. The first foundational building block is engaged leadership. High-performing practices have leaders fully engaged in the process of change. Even natural leaders must learn the science of how to facilitate organizational transformation. It's also important to note that high-performing practices have leadership at all levels of the organization, including medical assistants, receptionists, clinicians, and other staff who take on the mantle of changing how they and their colleagues do their work. Some practices also engage patients in leadership roles, recognizing patients as experts in the healthcare experience and uniquely able to identify priorities for improvement. The second foundational block is data-driven improvement. Practices need data and data systems to monitor their progress toward improvement objectives, whether clinical, operational, or experiential. Clinical metrics include measures such as the proportion of eligible adults up to date on cancer screening, and the proportion of people with diabetes whose blood sugar is under goal. Operational metrics include things such as continuity of care and access. Experiential metrics include patient experience assessments. To be most useful for clinic improvements, performance measures should be able to drill down to the individual clinician and care team level, and they are regularly shared with the entire staff to stimulate and evaluate improvement. To integrate data-driven improvement within the culture of a practice, data charts may be displayed in prominent locations on the walls of the practice, and performance data can be discussed in team meetings. The third foundational building block is empanelment. Empanelment means linking each patient to a care team and a primary care clinician. It is the basis for the therapeutic relationship that is essential for good primary care, not to mention continuity, Block 7, and patient team partnerships, Block 5. Empanelment is also closely intertwined with team-based care because teams assume responsibility for their patient panel. Empanelment is furthermore essential to identifying the practices and individual clinicians' patient population, and to then stratify that population's needs, Block 6. In a small, solo practitioner practice, this step may be simple, but it is important to understand how many patients are actively engaged in care for several reasons. For example, how does a clinician know what percentage of her diabetes patients have HbA1c levels greater than 9%? First, she needs to know the denominator. How many patients with diabetes are in her panel? Defined patient panels provide a denominator for performance measures. Block 2. Empanelment also enables the practice to calculate adjusted panel size, which determines whether each clinician and team has a reasonable balance between their patient's demand for care and the capacity to provide that care. When demand for care exceeds our capacity to provide that care, prompt access to care, Block 8, is impeded. Empanelment allows practices to adjust the workload among clinicians and teams. Unsurprisingly, empanelment requires constant monitoring. Now let's review the fourth foundational building block, team-based care. Did you know that clinicians caring for a panel of 2,500 patients would spend 17.4 hours per day providing all recommended acute, chronic, and preventative care? The growing shortage of adult primary care clinicians may further drive up panel size. Many exemplar practices have created teams with well-trained non-clinicians who add primary care capacity. Building teams that add capacity is called sharing the care. Many patients prefer to see a small group of people in their care team who know them well, such as the single physician and nurse that they might find in a small practice. For larger practices, the challenge is in recreating the relationships of a small practice. To address this issue, high-performing practices may organize their teams around teamlets, a stable pairing of a clinician and clinical assistant who work together every day and share responsibility for the health of their panel. Some practices have increased productivity or panel size by having 2 or 3 clinical assistants for each clinician. Often a larger team, perhaps a registered nurse, social worker, pharmacist, and behaviorist, support several teamlets. Some high-performing practices introduce side-by-side co-location of clinicians and non-clinician staff in common work areas called pods. They agree on ground rules that establish a respectful culture, perform daily huddles, and write standing orders empowering non-clinician staff to share the care. Practices may increase their panel size by assigning a subpanel of patients with uncomplicated chronic conditions to nurses or pharmacists who manage the chronic condition using standing orders. Let's now move to the second tier of the 10 building blocks model, starting with the building block 5, the patient-team partnership. An effective patient-team partnership recognizes the expertise that patients bring to the medical encounter, as well as the evidence base and medical judgment of the clinician and team. Instead of being told what to do, patients are engaged as active partners in a decision-making process that respects their personal goals and capabilities. For patients with chronic conditions, Health Coaching Block 6 provides a framework for self-management support. Building Block 6 is population management. High-performing practices stratify the needs of their patient panels and design team roles and targeted population health goals to match those needs relative to the resources available. There are 3 population-based functions that can provide opportunities for clinicians and staff to share the care: panel management, health coaching, and complex care management. Panel management involves a staff member, usually a medical assistant or nurse, checking the practice registry, flow sheets, or the health maintenance screen of an electronic health record to identify patients who are due for routine services like mammograms, colorectal cancer screening, and laboratory work for conditions such as diabetes. Standing orders enable panel managers to address care gaps without involving the clinician. In some practices, most routine care is completed before the clinician even enters the examination room, enabling clinicians to focus visits on patients' concerns, issues regarding the clinician's level of expertise, treatment options, and shared care plans. For patients with chronic conditions, health coaching entails assessing patients' knowledge and motivation, providing information and skills, and engaging patients in behavior-changing action plans known to improve outcomes. Research shows that health coaching can improve disease control, medication adherence, and the patient experience. When medical assistants, nurses, health educators, or pharmacists act as health coaches, they are usually given protected time to assume this time-consuming function. However, all members of the care team, including clinicians, can use health coaching skills in every patient encounter. Complex care management is the highest intensity of population management and generally focuses on people for whom traditional care is not meeting their needs. Some practices identify patients in need of complex care management by asking for referrals from clinicians, looking for patients with multiple conditions or psychosocial needs, or identifying people with higher use of emergency and hospital services. Teams headed by registered nurses or social workers have been shown to improve care and reduce costs for patients needing complex care management. Health coaching and complex care management take considerable time, and a small practice can benefit from outside organizations assisting them with these functions. Smaller practices contracted with an independent physician association, or IPA, may have access to a centralized complex care management function. The 7th building block is continuity of care. Continuity of care refers to the longitudinal therapeutic relationship between a patient and their primary care provider or care team. Continuity of care is associated with improved preventative and chronic care, greater patient and clinician experience, and lower costs. To achieve continuity requires empanelment, Block 3, which links each patient to a clinician and team. High-performing practices measure continuity for each clinician and achieve continuity goals of 75% to 85%. Reaching these goals requires the front desk staff to encourage patients to see the clinician to whom they are empaneled. Small practices tend to have high continuity of care provided they can offer consistent access to their patients. The 3rd tier in the building block model includes prompt access to care and comprehensiveness and care coordination. Let's start with building block 8, prompt access to care. Access is closely linked to patient satisfaction and is a prominent objective for many practices. Though the science of access is well developed, practices frequently fail in their efforts to reduce patient waiting. Our experience has been that practices are more successful at improving access in a sustainable way when they first measure and control panel size, Block 3, and build capacity enhancing teams, Block 4. Note that access and continuity may be in conflict if patients prefer seeing any clinician today rather than seeing their own clinician next week. High-performing practices allow patients to decide which takes priority. Building block 9 is comprehensiveness and care coordination. Comprehensiveness is the capacity of a practice to provide most of what patients need. Care coordination is the responsibility of primary care to arrange for services that it is unable to provide. When a patient's needs go beyond primary care practice level of comprehensiveness, care coordination is required with the other members of the medical neighborhood, such as hospitals, pharmacies, and specialists. In high-performing systems, including many systems in the IPA context, clinicians automatically learn when their patients have been discharged from the hospital, and specialist referrals are used to their greatest capacity because diagnostic studies are secured in advance by the primary care clinician. Improving care coordination requires teams because busy clinicians lack the time required to coordinate care for every patient with every healthcare institution. High-performing practices may include a care coordinator or referral coordinator whose sole responsibility is care coordination. The crown of the building blocks is the template of the future, building block 10. Few practices have achieved this ultimate goal, a daily schedule that does not rely on the 15-minute in-person clinician visit, but instead offers patients a variety of modalities to receive care, including e-visits, telephone encounters, group appointments, and visits with other team members. In a Building Block 10 practice, clinicians have fewer and longer in-person visits and protected time for e-visits and telephone visits. With a team empowered to share the care, clinicians are also able to assume a new role, clinical leader and mentor of the team. We've now reviewed the history behind the 10 building blocks and provided an overview of each block. So how can the 10 building blocks model serve as a framework for improvement? The 10 building blocks provide a practical, conceptual model that can help practices in the journey toward becoming high-performing, patient-centered medical homes, focusing on design elements largely under the control of the practice. Everyone has a different take on how to approach the building blocks. Fundamentally, it's a transformation journey unique to each practice. The 10 building blocks synthesize the innovative thinking that is inspiring the national movement for high-performing primary care. While the building blocks are not a universal roadmap, they can provide an overview that assists practices, including specialty practices, to transform. As an aid for practices wishing to assess their organizational changes within the building blocks framework, the Center for Excellence in Primary Care created the Building Blocks of Primary Care Assessment, BBPCA, modified from the Patient-Centered Medical Home Assessment Tool. Practices can use the BBPCA to assess their strengths while also identifying areas for improvement and transformation for each of the individual building blocks.